So for the 1 to 2 people in the audience tonight who don't know who Paul Farmer is, let me get you up to speed. Dr. Paul Farmer is the Chief Strategist and co-founder of Partners in Health. He is also the chair of the Department of Global Health and Social Medicine at Harvard Medical School. Can you read? Oh, there it is. And he is also the chief of the Division of Global Health Equity at Brigham and Women's Hospital in Boston. So when he is not overseeing Partners in Health's work in over 10 countries around the world, he sometimes finds the time to write, which is surprising. He has written extensively on global health, social inequality around the world. And tonight he will be speaking about his most recent book, which is titled To Repair the World, Paul Farmer Speaks to the Next Generation. It is a collection of his most memorable speeches, many of which are commencement addresses. So for all of you who are graduating soon, it is a very appropriate book to read before you leave the farm. It's an honor to really have him here at Stanford, especially since FaceAIDS was founded at Stanford back in 2005. Since then, FaceAIDS has raised over $2.5 million for Partners in Health. And, that money has supported Partners in Health's work, but it also represents U.S. students across the country who are advocating for Paul's vision of a more just world. The Stanford FaceAIDS chapter and Stanford Dance Marathon continue to fundraise for Partners in Health, and we're honored to have them in the audience here this evening. So, in addition to having him here, it's really appropriate that he's on a university campus. In addition to the hats that he wears as a physician, as an anthropologist, and a writer, he serves us as a teacher. Because when Paul Farmer and Partners in Health brought cancer care to Butaro Hospital in Rwanda, or when they treat patients with HIV and AIDS or tuberculosis with medicine that many deem as not cost effective, they are teaching the world to redefine the way we think of health as not a privilege, but a human right. And they are teaching us to redefine the way we think about healthcare as something that should be accessible to all. And in this collection of speeches, Paul Farmer teaches all of us to rethink about how we view our diplomas, not as a certificate of what we have accomplished, but a symbol of what we must commit to accomplish in our future, a symbol for the commitment that we should all make to repair the world. So joining him in conversation tonight is Jonny Dorsey. Jonny Dorsey co-founded FaceAIDS back when he was a sophomore at Stanford. Since then, in the 7 years since then, he's still been involved as a board member and also founded Global Health Corps, an organization that brings young professionals in partnership with global health nonprofits. They have placed over 216 fellows with global health nonprofits and have 100 more fellows joining them this month. So it's been a wonderful organization. Throughout all of his work, Jonny is now at GSB, but all of it has been inspired by the same vision of bringing more youth to commit to lives of service. So will you join me in welcoming our two guests this evening, Jonny Dorsey and Dr. Paul Farmer.
All right. Howdy. Thanks to all of you for coming tonight for this conversation with Paul about his new book, To Repair the World. This is going to be, I think, a really fun conversation because you all are the target audience for this book and the speeches that are in the book. Paul's other writing is also excellent, but it's a little different. And actually, Paul's friend Leslie's here, who is the only person other than his mom who's read all of those slightly more dense books. But this one is really for you. And That's why we're having this talk today. And that's actually where I want to start, Paul. I want you to think about when you were in the seats of the students here tonight, 30 years ago, and when you were preparing to go to Haiti. And I'd like you to say a bit about what you were thinking then, what took you to Haiti, and how that relates to why you've invested so much in giving these speeches to students across the country, and why you're here tonight.
Well, thank you, and thank you all for being here. Unlike students at Stanford, I had to go to Plan B when I was an undergraduate. And it's a good chance to tell this story. I was at Duke, and I knew I wanted to be a doctor when I went to Duke. I have no idea why I thought that. It's not like I had some doctor figure in the family. The only experience I had with healthcare was really not very good. It's when I was playing, you look at me and you know I should not be playing football with my brothers. And so, of course, one of my brothers was later a professional wrestler on television for 10 years. And when the Haitians saw him all these years later, they would look at him and say, "Same mother, same father?" Yes. And he's the smaller of my two brothers. So, of course, I broke my arm. What did my father say? "That's because of bad sportsmanship on your part." The next line was, "How about if I said it? We don't have insurance." And I said, "No, Dad, you're not going to set my arm." I was in 5th grade at the time, but stuck up for myself. So I didn't have any great experience as a student leading to go to med school. I took a class called medical anthropology because it had the M word in it, medical. Didn't know what it was. And I really thought I'd like to study this. And I wanted to go to West Africa, to Senegal. And I applied for a Fulbright. Now, it never occurred to me that I wouldn't even get an interview, much less the Fulbright. Hence Plan B. And I say that because I want students reading this book or hearing me talk to understand that there's a lot of serendipity involved in this book. Things don't work out the way you think they should very often. So that was really, in some ways, the best thing that ever happened to me because that's why I ended up in Haiti. Now, I worked at that too. I had won a small prize on graduation from Duke, and I was motivated enough and knew enough about Haiti to apply for that. But again, you get somewhere, and open your eye. It can open your eyes, and I think that's the value. A lot of people in this room are doing that earlier than I did. You don't have to leave the United States to do that. I, in fact, had gotten very interested in migrant farm workers in North Carolina who were Haitian. So when I say Plan B, it's not like I wasn't trying to get myself to Haiti or West Africa. And so that's the background story. Went there like a lot of you do, was interested in the rest of the world, but didn't know what I was going to end up doing beyond some vague notion of being a healthcare provider. Mm-hmm. That's kind of what you asked, right?
Yeah, that's the first part.
By the way, it's not true that I came here to talk about my book. I just used that as an excuse to come back and continue a conversation that I've had here with many of the students, including the Face AIDS chapters.
So you're here because you really value having these conversations with the next generation?
I do. Yeah, I do. I value those who...
Not making money off books?
I value those who had them with me when I was, an undergrad. Mm-hmm. And I actually had a lot of teachers at Duke and later at Harvard who took us very seriously. I mean, this was they were committed to teaching and committed to communicating. Now, most of them, granted, did not go off and work in places like Haiti or Rwanda. They were in North Carolina or in Cambridge or Boston. But they were supportive of that kind of work, and it meant a lot to me. Mm-hmm.
So I want to zoom ahead from that first experience in Haiti 30 years ago to ask you about what you did 3 weeks ago in Haiti.
Well,
and maybe you can tie a few dots in between the two. But I know this is a huge moment for you, a culmination of a lot of work since starting Partners in Health. So can you share what happened?
Thank you. Jonny said to me on the way in, we're standing right there five minutes ago. He said, do you want to review the questions? I said, no, it's a little late for that. But I'm glad I didn't, because the point is to have a conversation. But that first year, another thing about when you're telling a story to yourself when you're 22 or 23 or 33, you want everything to be coherent and to make sense and to show some clear trajectory. I bet you that I never told that story about not getting the Fulbright. And it's not like the first thing I would say, as a young medical student or a young physician probably. But it's important to figure out that part of the story. The first year in Haiti was very much like that. You'd say, well, I'm so glad I went here. I went to a town called Mirebalais. And, and that again was plan C. Who knows what plan that was? I had wanted to go somewhere else. I said, I'm here to volunteer at this hospital in another part of Haiti. And they didn't say, oh, thank God, Paul, that you arrived, 23-year-old, fresh out of Duke. They said, well, we really don't need you. And they didn't. And so I ended up working in this town called Mirebalais, again, by happenstance, serendipity, and sticking with it and just saying, I'm not leaving this country until I can be of service and learn some things that I didn't. But that first year, and I write a little bit about it in the book. I volunteered at a clinic, quotation marks, which are always hilarious. I had a friend who was a neon artist. He's since passed away. And he said, every time academics do like this, I'm going to make this little neon things that flash over their head. And so I don't use them all the time, but clinic, because it was terrible. There was one doctor who was really smart and a young Haitian guy. And we became good friends, as you might imagine. I was taking vital signs and writing down people's names. And there was no pharmacist, there was no registered nurse, there was maybe, the infrastructure was terrible, it was hot, you could barely move. I felt like I was going to pass out. The doctor, after it got really crowded, he would look at me, and I'd be, try to be, I was 23, I was trying to be cheerful, as you guys should do for me. And he said, every day at a certain time, he'd say, it's Valium time. And he wasn't talking about the patients. And, it was really a humbling experience to see that without the proper staff, without the proper infrastructure, we really couldn't do anything. And, I'm not even sure that if you went back and said, I'd like to do a rigorous assessment of this effort, the clinic, with a fully fledged, brilliant young doctor, not me, the other guy, I'm not sure we could have shown any efficacy. And I just thought then, I can't do this. He couldn't do it either. He just couldn't take it. And that it would be better to start again than to use this model of care again. The patients come up, they pay a fee, they get bad care. Little did I know, of course, it's like that all over the world, in most places in the world. So that's how I ended up in this squatter settlement. And what's a squatter settlement? A squatter settlement obviously is when you lose your land and your home. Could be for all kinds of reasons. This was a hydroelectric dam. And so then there was no clinic, no doctor, no nothing. And it was better to start again there from scratch. And we did. And that's how it started for me. That first year, and I know I'm answering a question, what's different 30 years ago? That first few years, really, we said starting again would involve doing a proper survey of the community and finding out what their health needs were. What is the community? Second time, thinking of my friend with those little neon signs lighting up. It was a bunch of communities around this hydroelectric dam reservoir. And they were all people my age. We were young, we were gung-ho, we were enthusiastic. We were like those guys playing volleyball out back. That looks like a movie set or something. Are there really people playing beach volleyball right outside, even though there's no beach? Only at Stanford. Anyway, so I'm actually making a joke because I get so upset when I think about this that it's hard for me to tell the story. these people became my very good friends, like I said, my age. And maybe of the 6 people on the Haitian side of the Ophelia Dahl worked on this project too. She knew all these people. One of them, Michelet, died, in agony outside of an operating room in Port-au-Prince after his ileum, his gut blew out with typhoid. Another, Asafi was her name. And I try to say their names. These are all people from that town, Mirebalais. She died she dropped dead in a psychiatrist's office after her symptoms of cerebral malaria were misdiagnosed as mental illness. And the third, whose name was Marie-Thérèse, who we all called T-Tap, died shortly after childbirth of an infection that has since been disappeared, in the Latin American way of saying it, from the first world by modern hygiene and antibiotics. So just because we started again in a new place did not mean that we could deliver the kind of care that you needed for those who were already acutely ill. Each of these people needed hospital-based care. And so we tried and we built a hospital. But as you said, 3 weeks ago, we had a celebration of partnership for the new teaching hospital in Mirebalais, which is beautiful and modern and is right now the largest solar-powered hospital in the developing world. And so it's a happy 3 decades for me. Very good. Very proud of it.
So
Have you guys been following this? Let's hope you're spellbound and not bored by it.
In your book, you talk a lot about failures of imagination, and you had to overcome a lot of failures of imagination in health circles, policy circles, everywhere.
Yeah, and in our own heads.
And sure. So can you tell the audience what a failure of imagination is and why it's such an important thing to overcome?
You can too, because that's what you and I talked about back when you were a freshman, when you were starting Face AIDS. And you can talk about the failure of imagination that led you to found Face AIDS. In my view, it's the same one that I just described. Can you deliver good quality health care for people living in extreme poverty? We didn't do it in that first year that I told you about. We tried, but whatever we were doing wasn't enough. We didn't even do it after we started again. And so I think what happens a lot is you get socialized for failure and scarcity when you're working in settings like that, and you start believing that it can't be done, that you couldn't have a modern hospital in the middle of central Haiti, that you couldn't have a CAT scanner, that you couldn't have an operating room where you could save someone's life even after they had a perforated ileum, perforated gut, or that you couldn't prevent that by building a modern municipal water system, or that you can't treat cancer, some of the things that Margot laid out in her introduction. That kind of failure of imagination is ours too. And I get why we have it, because it's difficult work to build things like that. And then there are other failures of imagination that are pretty spectacular. For example, the idea not only that we can't do it, but that it can't be done. Imagine trying to send a Range Rover or whatever it's called to Mars. It's not really called a Range Rover. That was supposed to make you laugh. And, if someone says, well, that's, improbably, it's a ridiculous mission because it's too technically difficult. Well, then, of course, it doesn't happen. Now, I'm not saying I want a bunch of Range Rovers. Well, actually, it would be good to send the Range Rovers to Mars. Then we'd have lower fuel bills. But I think that's what we face in equity work, in delivering high-quality care for poor people in this country and in other countries, is our failures of imagination. And they're worth identifying and then fighting.
Let's get concrete on one of these. Talk about cholera in Haiti and what the global health policy community thought needed to be done and what you guys pushed back.
Well, I think that what the global health policy community wanted to be done is still a good thing. I mean, obviously, we all want there to be proper sanitation systems, water and sanitation systems. But how long does it take to build a water and sanitation system? How long does it take to build a municipal water system? If you did it in Saratoga or in San Francisco, It would take a while, right, to do that. You'd hire companies, you'd put out bids, et cetera. But what about in the middle of an epidemic where you know it's going to be explosive and rapidly spreading as it was in, Boston, New York, London, all throughout the 16th, 17th, 18th. I mean, there were explosive, lethal epidemics of cholera in all the cities of the world and in rural areas. So we were only adding that we better say, an equity plan would have you say, okay, what are all the tools that we have to prevent and treat cholera? And let's line them up. This is a global epidemic. What's the highest standard of care we could use? And one of those interventions was to say, look, there are new tools that weren't there. I saw the tail end of another cholera epidemic, the last one in this hemisphere, in Peru. And that epidemic in the late 80s, early 90s just spread like wildfire across Latin America. And it was a marker, of course, of the lack of, again, water systems for poor people. And those needed to be, and in many cases have been built. But we knew we had this new tool, an oral cholera vaccine, and we wanted to bring it into play. We still do. So that was a clash because people would say, well, it costs a lot for this vaccine. Mm-hmm. But it's not like the vaccine costs a lot because it's made out of ancient Sumerian artifacts that could never be found, or some metal that lies in the mines of Moria or something. Thank you. It's expensive because we haven't put our minds to having it cost as much as we humans want it to cost. That's what we are trying to do with lots of vaccines, HPV vaccine. So that's a failure of imagination. It's not that it was hard to give people an oral cholera vaccine. You don't even need a needle. It's that we have to understand that things are often created by us, and that we determine very important matters like how much they're going to cost, and when should they be used for the public good as opposed to just as a commodity to sell.
What challenges do you feel yourself at times you're overwhelmed by? Do you feel like maybe you're suffering from a failure of imagination?
I certainly do. I mean, for example, the Mirbalais Hospital, we knew it was the right thing to do after the earthquake. And we had an incredible response from across the world, particularly the United States, people donating. We even had experienced implementers like David Walton, had been my student from the time he was 23 years old, and now at the time of the earthquake has already been working in Haiti for 14 or 13 years. And, as a faculty member with me. And we had another remarkable person signed up to help with this, a guy named Jim Ansara, who, by the way, I tease him, he's like Bill Gates, the Bill Gates of construction, didn't even graduate from college. He was at Amherst and dropped out and became a carpenter, like Jesus. only unlike Jesus, he built up a big company and sold it. Jesus didn't do that. But he did join the union, which Jesus definitely would have done. And so years later, Jim Ansara, not Jesus, had all these friends in the construction world, companies, union members, and he brought them, he said, let's bring everybody down to help build this. And Hewlett-Packard said, oh, we'll build the IT backbone. I didn't even know what an IT backbone was. I knew what a backbone was. But and lots of different people came, to help us. But it was really hard to finish, to raise the money, not just to finish the hospital, but to think about how to open it. Mm-hmm. There's just times when, you think, well, maybe we can't do this. Same thing happens all the time. When I see a patient with really terrible drug-resistant tuberculosis, I just really sometimes think, well, let me just say in China, for example, which I've never worked clinically there, but in 1 year, there were there are probably 100,000 new cases of drug-resistant TB in China in the year 2010 alone. That's the estimate from a recently published study in the New England Journal of Medicine. And 8,000 of those have so-called extensively drug-resistant disease. And you start thinking, this is so difficult to treat with the tools we have available to us. It takes a long time. People get sick. They don't want to take the medicines. It's miserable. And then you think, yeah, but the patients are willing to do it. So the failure of imagination, I think if you listen to patients and listen to people who are affected by these problems, you also buck up a little bit then too. But it happens to me all the time. And I work with a lot of people. Face AIDS is a good example. If you say, well, we're going to go treat AIDS in Africa, specifically in Rwanda, and you've got your lot in 2005 when you're 18 years old, 19 years old, saying, we're going to support you, it's hard to back out. In other words, the failure of imagination there should already be treated or prevented because you're vaccinated by the solidarity of a lot of other people. That was a mixed metaphor, which would not be
We won't hold it
tolerated.
against you. I'm going to pick up my paper, actually, because I want to read one quotation. And if failures of the imagination are one of the big problems that you talk about, another one is anesthesia to problems. And you use a lot of different metaphors there,
Mixed
too.
metaphors.
Mixed. The blue pill that Morpheus offers Neo is one of them. The general anesthesia.
I didn't make that up.
Is another. But at Stanford, a serious follow-up to your volleyball question is that we live in a bit of a bubble here, which people talk
really?
about. Small. And so you close with this quotation of one of your commencement speeches. Resting the easy anesthesia that privilege affords us is going to be your next big challenge. What do you mean, and how do we do it?
Did I say that?
You did.
I'm kidding. I remembered it. That was directed, if I'm not mistaken, to medical students, and on the day of their graduation, so really physicians. And it's a hard job. It's a very exciting job. And those of you interested in it, I encourage you to do it, same as in clinical nursing or clinical social work. These are direct service delivery, frontline jobs, if they're done right, I think most of them. But you get overwhelmed, and these failures of imagination come into your mind as a clinician, it's not that people say, well, this person is too sick for me to take care of, right? On the day of the Boston Marathon bombing, nobody who's a clinician, or that is a nurse or a doctor, is going to say, you know what, this person is too badly injured for me to take care of. That's not the problem. The problem often is that your world shrinks down to not just the patient in front of you, but to your institution, the hospital, sometimes it's a clinic, and you forget about all the social forces that make some people patients where other people don't even have access to care. That's the anesthesia I was talking about to them. I could have given a very similar address to policymakers. They forget the big picture too, even though that's what they're supposed to do. It's like big picture Inc., right? Is policymaking, but everybody can forget the big picture. So the big picture is very disturbing to look at. You're in the middle of rural Haiti when you're 23 years old and thinking, I really don't want to look at all these pathogenic forces. Displacement, political upheaval, bad domestic and foreign policy directed toward the Haitians, 200 years post-slavery, becoming pariah state in the 19th century. It's scary to contemplate what it would take to change the impact of that. And so anesthesia, I understand it, meaning the seduction of simplicity, of making the boundaries of your world a bubble. So I do think you're following up on the bubble question. It's not that I'm saying I don't think there should be a very artificial looking beach out there with a net on it. There's nothing wrong with being in a bubble if you understand that it is a bubble, that it is an island of privilege, and that you're walled off, in a sense, from the rest of the world. It's not that it's not the real world, although it does have a certain feel of that at times in some of these places. It's that you're part of a real world that has a lot of disturbing problems. And they're not going to go away. The ones in front of us today they're even more complicated, perhaps, than stopping slavery, which was complicated enough, or fighting for universal rights or suffrage. Those were complex enough and difficult and great achievements. But I don't imagine that climate change is going to be an easy topic, or health equity in this country or any other. I think these are really going to require a lot of people pulling together. And even those in the bubble, understanding that they're not part of three worlds, first, second, third world, but one world.
Many of those at Stanford who want to break out of the bubble and do what Jane Stanford called students to do, be of greater service to the public, turn to social entrepreneurship. Stanford is sort of the epicenter of entrepreneurship
So it
for the
keeps
world.
telling me, yes.
Yep. And for those who want to do good, the social entrepreneurship track is extremely popular.
Yeah.
And when you won the Skoll Award for social entrepreneurship, you said that you were sort of surprised to be called a social entrepreneur, and you gave an acceptance speech, or a speech of some sort, that both thanked them, but also shared a few critiques of social entrepreneurship. And so
My brother, the former wrestler, says that's my specialty, the judo move of both thanking them and kind of jabbing them. It's like intellectual jujitsu. I did do that.
So
I do that.
What'd you say? And maybe let's focus on the critiques. I get like 10 more minutes of my own questions, so let's focus on what you think needs to change.
Can you give me some prompts? What did I say? That was many years ago. No, I know what I said. I think one of the points that I was trying to make, and I hope graciously, because these people, I hope that maybe some of them are here. My friends from school, major supporters of Partners in Health. The idea was not directed towards them, but towards any movement that thinks of itself, or any effort that thinks of itself as innovative, if you actually do something surprising like deliver services to poor people. Now that should not be entrepreneurial. To say, oh, gee, I'm a doctor, there are these sick people over here, it's going to be really entrepreneurial to help them. It's going to be an innovation. It's going to end up in the Stanford Innovation Review. So it was, a challenge to say, look, let's make it less innovative to actually serve poor people, and make it just a matter of course that if you have some basic rights, including the right to health care, the right to education, the right to clean water, that we all move towards that, even if we don't use the rights paradigm. I think that's another point of that, is there are lots of complementary paradigms. There are rights paradigms, sure. Not everybody buys into them. Poor people, by the way, find them very powerful. The social and economic rights paradigms, in my experience, in Peru, in Haiti, in Rwanda. Again, it's not the culture so much as the experience of being subjected to really brute poverty and saying, wouldn't it be nice to have a right to clean water? To know that if you drink water, I'm drinking water here and I'm thinking, boy, that tastes a lot like cucumbers. Mm-hmm. But I'm not thinking it tastes like cholera. I don't think there's any stool in this water. Wouldn't it be nice to have a right not to get cholera when you're drinking water out of a glass that a stranger, hey, wait, who gave me this glass? Gave you. Not everybody likes that. What are some other paradigms? Well, there's, the notion of breaking this cycle of poverty and disease is a good investment. I don't care if people say that. I agree with that too. Or that there are certain things that ought to be considered public goods for public health, like, not getting cholera when you have a glass of water, or not getting tuberculosis, when you're in a classroom or in a hospital. So, trying to move forward this set of paradigms is really, that's innovative. That'll be innovative when we can move that forward. All the years that I've been coming here to Stanford, face AIDS was really a great innovation. I'm still not on Facebook. I promised my daughter, okay, I won't. But using new technologies and social media to communicate about a complex problem, and then to find resources to respond to it in a place like Rwanda, That's innovation. And I think we need more of it. Obviously, we need lots of new tools, but we need to not forget that just because you get a new tool, like a new app for mobile health, doesn't mean you've got the delivery problem dealt with. Just because you get a new vaccine to prevent cervical cancer or some other problem doesn't mean you've got the vaccine delivered. That delivery problem calls for innovative solutions too, and not just in places like Rwanda and Haiti, but here in the United States.
So it's certainly very nice of you to say those things about face AIDS, but one could argue the
All I'm
exact
asking
same
is for
thing.
$2.5 million more.
You could say the same thing about face AIDS as PIH, that the idea that those with access to support and resources should leverage some of them and give them to those who do not have that same access should not be innovative. And similarly, that young people should be at the forefront of a social movement is certainly not innovative, and in fact is seen in every successful social movement.
That's right.
And that's where I want to actually ask my last question. You talk a lot about movements. You've done so a few times tonight in your book.
But don't confuse that with the cholera comments, because I don't want to have any movements
No bowel
related
movements tonight.
related to cholera.
But you're a little obsessed with the abolition of slavery. Good thing to be obsessed with, and that movement and its success and the perseverance of its leaders. You talk a lot about King as a leader. And I'm curious, actually, in the first time we met, you pulled out the Partners in Health annual report that had building a movement on the cover as the ultimate goal of what you all were doing. Why are social movements the only way to, or at least the way that you emphasize, making real change? And how do you think this audience can ensure that with our lives, we not only say no to the blue pill and not only avoid failures of imagination, but build lives and careers that are about social movements for change?
Well, just to go back to that example, I mean, it's hard for me to imagine that if you think poor people in this country or any other should not be subjected to such outrageous risk, of bad things happening to them, then that it's hard for me to imagine that a philanthropy or an NGO like Partners in Health, and I believe in Partners in Health with my whole being, but it's hard to imagine that as the ultimate answer for reducing, risk for people who are, rendered vulnerable by poverty, racism, earthquakes, and these things run together too. I don't believe that. I don't think that's enough. They should not, we're always subjected to this barrage of critique or even just a quiet undertow of censorious opinion along the following lines. It's not sustainable, it's not cost effective, it's not feasible. I mean, they varies, but it is definitely not it's the opposite of saying, obviously we should do this. It's saying, really, how are we going to do this over the long term? But if you have social movements, it seems to me, looking back at those examples you gave, the civil rights movement in the United States, which isn't over by any stretch of the imagination, and the abolitionist movement that it didn't begin in Britain in the late 18th century, because it began in slave colonies, but it spread and was picked up by people who themselves were not slaves, but said, this is outrageous. And the way that it became unacceptable, for example, going back to the civil rights movement, unacceptable, I mean, in my lifetime, I've seen restrooms that say black women, white women, et cetera, et cetera. And I'm only 53. And, that's completely unacceptable, and everybody knows it. And how does that happen? How does it happen that in the age of the Enlightenment, slavery boomed in the Enlightenment? It was the heyday of slavery. How could that happen? That you could sell people as things. And, anthropologists are obsessed with culture change. And culture change is frequently related to social movements. So, maybe it's not the right term, but I'm obsessed with them because I think it's so obvious to me that Mirebalais, the town that I was talking about, needs to not have people dying like my friends did back in the 80s. And to say nothing about people I've never met. It's so obvious that after an earthquake where the teaching hospitals of Haiti were destroyed, it should be one of the first order of business to build a new hospital with that kind of capacity, including, heaven forfend, a CAT scan. No public hospital in Haiti had a CAT scan, by the way, until this one was put there. So if it should be obvious and isn't, then you start thinking we need social movement so that everyone says, well, as my daughter would say, well, duh. You need, you have this big district, let's say in Rwanda or Malawi, there's no hospital, you need a hospital. And it should be a modern hospital. So I think, it's a long-winded way of saying social movements sometimes make the obvious but ignored obvious and not ignored. And that's the power, to me, of this generation's engagement. To say it's I don't know what the latest term is. At least you guys aren't called being part of the me generation. I think that was my generation. But to say that young people aren't interested in social justice is obviously not true. And we need to make it routine to not accept these kind of outrageous disparities.
So now they're going to get to ask you some questions. There are going to be, actually, we're going to do mic runners, I think, but maybe there are not going to be.
Calling the guys playing volleyball, they can clearly run.
So let me give a few tips before we start the questions. Questions should take less than 3 sentences and end in a question.
Like that'll ever happen.
Not be statements. And that's the only main rule. And we'll bounce back and forth. But I'm just going to say, well, Paul would not do this. I am going to cut us off after 20 minutes of this. So let's not form massive lines behind the mics. But if you got a really good question you want to ask Dr. Farmer, then hop up. Sam, kick us off.
Howdy. So I agree with you on a lot of things about the importance of social movements, but I'm also a computer scientist in Silicon Valley, and I think that we probably have a lot to offer. I was wondering if you had some thoughts on how computer scientists can help.
Yeah. Well, for one thing, if you go back to the example of the abolition of slavery, and I got a lot of this. I'm actually tomorrow at San Francisco, I'm going to be having a conversation like this with Adam Hochschild, whose book I would recommend to you called Bury the Chains, which I think was 2005, that same, may have come out about then. But what he described, he tried to, this is what good writers do. This is why nobody ever buys my books, because I call them things like Women, Poverty, and AIDS. The global threat of drug-resistant tuberculosis. That one sold a lot. So what Adam Hochschild does is tell the story of Thomas Clarkson. And when that group started passing around petitions across England, remember it was a monarchy. If they had you in Silicon Valley with the tools that we have today, they wouldn't have been riding around on horses. They would have sent stuff out, blitzes by email. And I'm just saying, imagine the power of a social movement today without the tools that a lot of them have come right out of this valley. And so I think for a computer program, obviously you're writing code. Of course, I have no idea what that means. I kind of do. And it may be more obvious that if the social movement under discussion is the health, right to health care, especially right to health care for poor people, that a physician or a nurse would have a more obvious role. I don't think that's true. What I'm talking about is social movements that are broad-based. So I don't know that we really could have a meaningful social movement in modern times without drawing on just the enthusiasm of people doing what you do. Now, that said, I think there are other things that can come out of this valley. Technology platforms. I told you about the hospital briefly. You can't have a modern hospital without modern diagnostics. You can't have a medical record system that isn't an electronic medical record system and expect to be able to follow large numbers of patients, no matter what it is you're doing. And I could just go on and on about some of the challenges that we've had in Partners in Health because we didn't have programmers readily available to us, to help write code. We had some to help write code for electronic medical records. When we started doing this in the 90s, imagine how quickly we could have done this with, an army of programmers who were focused on health equity. So we still need the specifics of your trade, but also the general support that we're hoping will come from, again, this broad-based movement.
Thank you.
Thank you.
There's been a lot written about how much of the money that went to Haiti after the earthquake was wasted. And I'd like to ask whether you agree with that and what thoughts you might have on how to be more efficient in the future.
Well, I have no doubt that a lot of money that got sent to Haiti after the earthquake was wasted. But in terms of the official pledges for reconstruction, most of them have never reached Haiti. So it's really important that we understand that. So the delivery of a promised service or a project obviously requires the resources to do it, so the pledges never get there. The confusion between aid pledges and aid delivered is really a major one in Haiti. Another thing that I will say is how to make it more efficient. I'd be glad to inundate you with specific examples. We're all very interested in this, is how to rewrite the rules of the road for aid to focus on not necessarily the middle man and middle woman who are right now in this machinery, but also to focus more on local job creation, local capacity building, and the actual implementation itself by Haitians. In the example of the hospital, I gave all of the building of that hospital, whether it was done by volunteers from an electricians union or some other place, it was to train other people. So it was a teaching hospital even before it admitted the first patient. I think there should be more of that in the work we do in Haiti. Finally, we need to become greater than the sum of our parts, right? All the NGOs that are working there. And that's hard to do, the coordination. But there's been as much lack of coordination as waste in the conventional sense. So I think it's a very complex topic, but I'm glad you brought it up because I think there's a lot we can do to make it better. I've used this term in this book called accompaniment, and I'd invite your critical reflections on it. A better way of approaching it than aid is long-term accompaniment.
I was wondering, as a role model, how do you balance your commitment to the people you serve and the work that you do with the family you have? And as a mentor, how do you advise young people to do that?
Well, I don't really sign up for the role of a role model. It's like you check a box saying physician, role model. I don't really do that. So what you really need are lots of role models, right? Because I mentioned the people I've mentioned in this book, in other words, they're not very often physicians. If they are, they're physicians you may have never heard of, like Rudolf Virchow, who I'm told once challenged the Chancellor of Germany to a duel, which, after my experience with my very large brothers, I am a total pacifist. And then there are people that Jonny mentioned already, like Martin Luther King, who are role models for engagement, although none of us would wish to suffer the fate that some of the people I mentioned did suffer. I don't think anybody who wants that needs a different kind of medical care. So in talking to students, I would say, look, you got to find a way to be involved in this work that fits you, And, if my mother with six kids, by the time she was 28, did what I'm doing, we would not have had the chance to grow up to be big brothers like my brothers who ate so much food, shoveled it in. And, that doesn't mean that my mother, for example, didn't make good choices about how to get involved in social justice work. I would never say that and don't believe it. What I'm really saying is you have to have all kinds of approaches to this. I've worked with a liberation theology priest who I much admire, named Gustavo Gutierrez, and he became a good friend of mine. He's Peruvian. And I was giving a talk with him at Notre Dame a couple years ago, and he was saying, look, this may have been the part where he's speaking in Spanish in a different session, but he was saying there are 1,000 maneras, 1,000 ways to serve the poor. And I think there's 1,000 ways to serve the poor and to get involved in movements, and that the really important part is to find the coworkers you'd like to work with who are doing the kind of work you'd like to see done. That's how Face AIDS and Partners in Health came together. It's not some prescriptive career advice that like a mentor might give about career balance and work-life balance, all those things. I don't pretend to have that kind of expertise. I would just say everybody could and should get involved in the work. And hopefully, you'll bring your kids into the work too. It's another big part of what I think should happen. It'd be great if the next generation, including some a lot younger than you, are involved in this work, meaning literally our kids.
Thank you.
Thank you.
This next one's a little bit dangerous, Paul. This is Allison Dorsey.
So, Paul, there have been a lot of articles
How are you, Allison?
written recently on the gross corporate excess of Silicon Valley and things like $20 million being spent
The GCE?
Yeah, exactly. So there have been things like $20 million spent on sales training conferences and these expenditures that are irrational. And I think that a big defense of these that companies would make is that they use it for recruiting, that they're going to get the top talent because they'll send you to Vegas for a week of training. So assuming that we're all right and this generation doesn't just want a week in Vegas but really wants to serve the world in a greater way, how can we be part of a movement to redirect that capital from these companies here towards the greater good?
Well, first of all, I like the question. I haven't met that many people in my teaching who would choose a career based on a week in Vegas. I mean, maybe they'd choose not to do that career, depending on their experience there. Of course, now I've only been there one day in my whole life, and that was plenty. In my defense, I was giving a talk at a cancer laboratory meeting. So, again, that doesn't seem like a very smart recruiting strategy either. Maybe it's a blowing off steam strategy. I don't know. I'm not really familiar with it. I think that one way to do this is to go into the companies, to be part of the companies, not necessarily as an employee. That's why I'm here. This is my recruiting strategy, is to show up at Stanford and talk to, people who are young and bright and promising and say, there's a place for you in this work. And it's not been a bad recruiting strategy. And when you get people who are working in these companies, in this part of the world or in some other industry, and try to get them to have different policies, around what it is they regard as their responsibility in this world. And again, I have some good stories too, like the example I gave you of Mirbalais. That's a hospital that was born out of partnerships, including some very unlikely ones that would not have occurred if not for the earthquake. I think we should lift those up and find others, of course. I'm just talking about the ones I know. Because it should not be so hard either for the implementers or delivery people doing work like this to find the resources. Human capital, in other words, like the example of computer programmers. So I guess part of it is you, all of us, should be more committed to understanding our role as links between, I'll just call it the rich world and the poor. And of course, that doesn't mean there aren't poor people in this country. When I say rich world, I mean rich people's world and people, living in poverty regardless of where they live. And I know that, I guess what I'm really saying is that a lot of it has to be about human connection, about understanding that, there's got to be a way to bring more people into this work. And I don't know how to do that except by actually going and talking to these people or having people like you go and talk to them and see who inside any place like this, even some crazy bank on Wall Street that does weird things with mortgages I don't even understand. There's people in there, and in every bureaucracy, no matter how stubborn or reactionary, they're created by humans. The bureaucracies and companies are created by humans. And we have to say we've got a role in shaping them and their practices, and whether we're part of those companies or not, we're part of them. Same with all these government bureaucracies when we're unhappy with them. That's hard to do. In fact, that is, for me, much more discouraging at times. The failure of imagination hits me most around those issues, and not around direct delivery of care to sick people. Mm-hmm. So let's keep at it, is what I'm saying.
Hi, my name is Vanessa. You kind of touched upon this in your last response, but so some numbers that have been thrown around in my classes have been that after the earthquake, 1% of the aid went to the government, then 99% went to nonprofits, charities, federally funded programs. And I guess in terms of, just curious about what do you believe is the role of the government, especially the Haitian government, in improving the healthcare, and is it even possible, especially with the many coups that they've had the past couple hundred years? And yeah.
Yeah, that's a great question. Even if the government capacity was reduced really to nothing, and after all, and I'm going to give an example of a place where that happened, even if it were reduced to nothing, you'd really want to rebuild it, right, the capacity. Example, Rwanda in 1994. And this is, one of the things I almost forgot to say, is that it would be a big mistake for me to come back to Stanford, where I made a very public pledge in 2005 saying Partners in Health is going to be part of the renaissance of Rwanda's medical capacity in the public sector, in the government. And I did say that then, right here, right? So has that happened? Yeah, it has happened. In fact, the return on that, and I'll go back to Haiti in a second, the return on that investment by Partners in Health and its many partners, including FaceAID, working with the government to rebuild, and they'd already started, of course, over many years after 1994. But the places we went to had no district hospitals at all. They had no hospital infrastructure with physicians working them, none of the 3 districts. So now they have lots of infrastructure and also lots of community health workers, really literally thousands of people and tens of thousands working to deliver health care for poor people. So the return on that investment, to use an expression from the private sector, has been enormous because the life expectancy at birth in Rwanda has doubled in the last 10 years. I knew it would work, but I didn't think it would work that quickly. The reduction of child mortality and of deaths due to AIDS, tuberculosis, and malaria, and deaths during childbirth have plummeted by 60% and more in just 10 years. And I would also add those are the steepest declines in mortality ever recorded anywhere in the world at any time that we know about. I mean, if that isn't a return on investment, I don't know what is. So what about Haiti? Well, Haiti has had a long-standing divestment from its public sector institutions. There's a weak or corrupt, you can say corrupt all you want, but if it's weak and your job is to deliver healthcare services, you have inadequate budgets, you can't do the work. And then the earthquake comes along and certainly takes down all of the public federal infrastructure in Port-au-Prince. I mean, imagine that happening in this country. You couldn't do it because it'd have to be simultaneous earthquakes in lots of different cities to take down our federal infrastructure. It's not just concentrated in Washington. We have federal buildings in California, Chicago, Oklahoma, everywhere. So that was really a big blow. And I, like everybody else, I'd like to forget about it. The actual time of it and what the Haitians especially went through. But it's going to take a long time to rebuild that. So I would say to put less than 1% of the immediate relief aid through public institutions was a mistake. What if it were just 10%? How much would that have sped up recovery of public sector capacity? I think it would have helped. We've got a long way to go until we rebuild that capacity. I think we should keep trying. I know Partners in Health will. That hospital that I mentioned, I didn't build it. The hospital that I mentioned that was built by my colleagues is a public sector hospital. Could they have built the hospital? No. No place in Haiti could have built that hospital without the kind of skills that we brought in from all over the world, particularly in the United States and Boston. But it could be built for the public sector, and people could learn how to manage it and run it over time. That's what we're hoping to do.
Thank you.
Thank you.
Before we move on, can I get you to put a little bit more of a fine point on this and why it is essential? And let me try to articulate the counter-argument that's, I think, very popular here.
Yeah.
If you go with these slow governments, be
Yeah.
they in Sacramento or Haiti, you can deliver services much more slowly.
Yeah.
And we need to show what excellence really is, not to mention meet those patients, those students, what have you, as quickly as possible, and not let ourselves be dragged down by these slow governments. Sure, if you believe that the government's the way you have to deliver it in the long run, then you have to go with them. But why does it have to be that way?
Well, I would say that's not a bad argument, right? The question is, do you break apart the private actors, whether an NGO or private sector of other sorts, from any aspirations to build public sector capacity over the long run? Is the long run, I told you already, and I know you're setting that up as a straw man, I'm just shocked about how rapidly changes occurred in Rwanda. 10 years is a very short time horizon for such a radical, positive demographic change. If that's regarded as super long term, what about the 50-year horizon to build, massive public infrastructure, roads, transportation, clean water? You really just have to see how we can move quickly and bring in this public sector capacity. Again, it could be district governments, town governments, local governments. It's not like you're going to have to wait forever. Most places are not like North Korea, or Burma not too long ago. They're not really closed. They're open. And the method of our engagement, the mechanisms of our engagement matter. And let me tell you, I feel like it's a lot easier to work unfettered. There's so much more latitude. You can be really nimble, move quickly. The question is I've been doing this 30 years now. And I'd like to see the health and well-being of people who are sick in Haiti, for example, not depend on the kindness of strangers, humanitarians, missionaries, not depend on. We all have a role to play, including missionaries, humanitarians, people in NGOs, students certainly. But it needs to be a role that's humble enough to allow for local capacity building in the local private sector and in the local public sector too.
All right, people, the mics will be our last two questions, then I'll talk about book signing after that. So I can't remember which side we were at. Go ahead.
So to many, a pediatric oncology hospital in Rwanda wouldn't seem like an obvious need. So
Yeah.
could you speak to how that need was identified and what the response has been in that specific case?
That's a great question. It's an interesting, I got some of my colleagues here too, like Matt Craven, who can get my back, even though he's from Stanford, not Harvard.
I heard he's going to Lesotho soon.
Yeah, I've got to head that way now. He's a physician, trained at the Brigham, and helped make this, what I'm about to describe, come to pass. So when people said it's not obvious that you need a pediatric oncology hospital or facility in Rwanda, you'd think it was because there was no cancer among children there, but that's not true at all. There was plenty of cancer among children and adults, but there were no cancer doctors, cancer nurses, cancer facility, cancer drugs. So you're right that that's what people said, that this is not a ranking priority, but what they really meant is we don't know how to do this without resources, staff and stuff. Staff like oncologists and stuff like special hospitals to treat cancer. So what we did is say, well, none of us is an oncologist on site, but imagine if I said, in order to treat AIDS, in Africa you need to have infectious disease doctors like me. We knew that wasn't true. I happen to be an infectious disease doctor, but that's not why we were able to get so many patients in Haiti on therapy. It's because we work with community health workers, nurses, administrators, et cetera. So we use the same logic to say, look, there's a lot of cancer here. We do need specialized training and care, and obviously the drugs and diagnostics to make this happen. Let's build that capacity. But again, back to short-term, long-term. Same story that Jonny just told, and that you know very well. We said, in our short-term plan, the NGO will drive this forward. And we're going to have partners. Who are our partners? The Dana-Farber Cancer Institute, the Brigham and Women's Hospital for the pathology, Dana-Farber for the diagnoses and chemo. You know, a race car driver, for heaven's sake, Jeff Gordon. I tell you, I meet all the strangest people in this work, unlikely allies. A race car driver, you know, gave some of the money. And Livestrong, you know. So we got all these partners together, worked for the Ministry of Health, and said, we'll make this happen. And then back to the previous comment Jonny made, we know that you'll want to scale it up since, as we said, there is a lot of cancer in rural Rwanda, but not a lot of cancer doctors. And that's what I was describing to the Face AIDS crowd, that's the burden and equity approach. You'd understand the burden of disease, you'd find cancer right up there, along with road trauma, major mental illness, and then look at what's being ignored by everybody else and move towards that. Not by the patients and their family members, but by those who are, you know, making decisions about what to do, what policies to pursue. It's a great question.
So my question is that ethically, I definitely feel the need for health equity for all. But when I look at the exponential increase of the population in the world, it just seems really daunting. And then, and this could even tie in with the failures of imagination that you mentioned, that you can start making kind of ethically dubious claims like, well, if you ensure health care for this or that population, then you're only ensuring their longevity and adding to the population of the world. And so I was wondering, how do you balance the need for health equity for people with this sustainability of it question that ties in with the population growth?
Well, I think that's a great question. And you know, I remember the first time I started hearing that question, probably 20 years ago, and I was inexperienced at answering it, right? Because I thought, wow, I never even thought of that. Why would longevity be a problem? That's what I was trained to do, promote longevity. And so it's possible, I think, for people like me to make the mistake of not learning more about thinking about that. And here's what I would say as an ethical response to that. And anybody should feel free to ask that, right? If we have a big problem on the planet with overcrowding and overpopulation, why isn't everything that we do to promote life and protect life on the wrong side of the ledger if we're trying to have less population? And you know, the ethical answers to that are all around, well, let's say that, you know, rampant epidemic disease is not a good way to control population size, right? Or that war and genocide are not acceptable ways to control population size. Or any of the other long list of, you know, bad things that are done or come to pass among poor people. So what are the right answers? Well, first of all, from the point of view of some people living in poverty, it's not so much the overpopulation of the earth that strikes them, in my experience, but the unfair sharing of the world's bounty. Like, I don't really hear that much from, you know, people, patients and poor people in really crowded countries about how crowded it is. That's what I think. I mean, I'm going into some of these places and thinking, oh my God, it's so crowded here. You can't even move around 2 feet without bumping into someone else, you know? But that's not what I hear. What I hear them saying is, you know, we can't make it because we don't have enough to eat and we don't have a place to live and we're crowded. So we need to understand, those of us who are not poor, those of us who live inside a bubble of one sort or another, that a lot of people don't see this problem the same way. The other thing I would like to say is, as any good Catholic boy would, is if you say, well, you know, the Black Plague wiped out a third of Europe and led to the Renaissance, right? You've heard stuff like that, right? You know, I think we would say, well, those are claims of causality that we had better interrogate. And even if a reduction in population size led to some kind of boom in resource sharing. Certainly not the way we do it now. You would not release Yersinia pestis into, Tokyo and say it's really crowded in this city. And nor would you do it in other places like San Francisco, where there's a lot of people per square foot, but they can pretty much live much more safely than they did in 1900, when in San Francisco there were enormous outbreaks of infectious disease problems, including the plague, right? So the real trick, I think, in having conversations like this is to say, we understand a lot more about family planning, about other ways to choose ourselves as a species rather than having a microbe choose for us. And, with AIDS, you could say 34 million people with AIDS. Well, there's a lot of people on the planet. That's okay. That's, of course, not at all how it plays out. You lose the mothers and fathers, the parents. You lose the ability to, teach children, grow crops, work fisheries. It's a nightmare when you let these noxious forces and pathogens choose for you. We should choose. And I think we have, not one of those people who believes that technology is the answer to everything. I think solidarity with others is even more part of the ethical answer to this question. That what are the solidarity-based ways of dealing with some serious problems, the ones you mentioned and others that I mentioned too, climate change, et cetera. What are solidarity-based ways that draw on all of the technology we have and some of the technology we don't have yet but will? Thank you. It's a great question.
Thank you very much for coming.
So I'm going to just share a few logistics, and then Paul will have the last word. So Paul's going to stay on stage after he finishes and sign books for those who want books signed. If you have one on you, great. If you want to have one on you, they're being sold just outside the back door, so you can grab one there and then come up onto stage to say hi to Paul and ask him to sign your book. And there will be a few people helping manage that process, and be kind and listen to them if they ask you to do something. And before you get the last word, I'll just say thanks so much for coming here, Paul. It's a huge honor for me to get to have this conversation with you, and I think you're sharing a really important message to all of us. So thank you so much.
Thank you, Johnny. Well, if I'm going to get the last word, it'll be two of them. Thank you. Again, sometimes you just, none of us has the time to step back and look at the big picture, as I said a lot repeatedly in this book. And that's an important thing for everyone to do, including, someone who's now middle-aged, who doesn't want the Middle Ages to come back, by the way, in case you missed that on the plague references. But someone who's middle-aged, I've been doing this a long time, 30 years, since I was the age of many of you here. And one of the things that I've learned in the last 10 years is that there's just so much, even more power in partnership than we imagine when we, in our 20s, named this organization Partners in Health. Clearly, we knew partnership was important. But the degree of our conviction and the depths of our conviction that partnership is important has only grown over the years in this past decade as much as any. So special thank you to Face AIDS, to the campus bubble that spawned its first iteration. And I just hope that the next decade is going to be even better. I believe it will, because I believe in a lot in this next generation, so beautifully represented here tonight. Thank you very much for having me back.